Subscribe YouTube channel Concepts of the Surgery for best video lectures on surgical topics. Main hallmark of chronic pancreatitis is fibrosis of pancreatic parenchyma. Due to continued insult, a cascade of events sets in, leading to continuous non-stop fibrosis. This fibrosis, apart from affecting glandular and endocrine function of pancreas, it causes problems like bile duct stricture causing jaundice, stricture near ampulla leading to jaundice with pancreatic duct obstruction. Fibrosis around pancreatic duct leads to strictures, which at times could be multiple. Stricture leads to obstruction to flow of pancreatic secretion and increased pressure in duct, causing so-called ductal hypertension. This ductal hypertension is one important cause of intractable pain in chronic pancreatitis. Apart from increased duct pressure, stagnation of mineral-rich secretion leads to stones in pancreatic duct, further obstructing flow. There are some basic rules for surgery in chronic pancreatitis. On MRI, if there is a mass in head of pancreas, then carcinoma can be present, plus mass also can be epicenter of pain. As chronic pancreatitis is a risk factor for pancreatic adenocarcinoma. Fine needle aspiration cytology of head mass done by endoscopic ultrasound can be negative for two reasons. Pancreatic cancer has low cellularity with large proportion of stroma, plus fibrosis and tumor and background also may lead to decreased sensitivity of FNAC. So, rule number 1 is any mass's head should be removed to remove epicenter of pain in malignancy, if present. Second rule. If there is generalized enlargement of head, then this is epicenter of pain and also stricture of common bile duct and pancreatic duct. So rule number 2 is that enlarged head should be removed. Next rule, if there is no suspicion of malignancy on MRI, then duodenum should be preserved while removing head, as removing duodenum further adds to malabsorption, already present in chronic pancreatitis. Rule number 3. Preservation of duodenum, if no suspicion of malignancy. Next rule, if pancreatic duct is dilated, then it means increased pressure in duct which causes severe pain. So rule number 4, dilated pancreatic duct must be drained. Let's revise all rules before we proceed for surgery. Mass's head should be removed. Enlarged head must be removed. Preservation of duodenum, if no suspicion of malignancy. Dilated duct must be drained. Two things are noted in MRI and chronic pancreatitis to decide what surgery is needed: head mass or enlargement and ductal dilation. There could be mass with normal duct, dilated duct with no mass, head mass with duct dilation, enlarged head with normal duct, enlarged head with dilated duct. Chronic pancreatitis limited to tail. Severe pancreatitis involving whole pancreas. Scenario 1. Localized mass in head with normal duct. Localized head mass is highly suspicious for malignancy, and FNAC is not accurate in ruling out cancer, so in such cases, pancreatoduodenectomy is done, also known as Whipple's surgery or Koch-Whipple's, as known in some countries, giving credit to Koch who did pancreatoduodenectomy before Whipple's. Scenario 2. Normal head and dilated duct. In case of ductal dilatation, Puestow performed a procedure called caudal drainage. In this procedure, tail of pancreas is removed with spleen, and jejunum is anastomosed to transected end for duct to drain. Results were not very encouraging in terms of pain relief, as duct usually has multiple strictures and stones causing inadequate drainage of pancreatic duct and jejunum. To overcome this problem, Parlington and Rochelle modified Puestow procedure. Duct was opened longitudinally and anastomosed to a long opening in jejunum, so spleen can be preserved, leading to less blood loss. All stones can be removed and all strictured area are also drained. Scenario 3. Localized mass in head with dilated duct. In such case, as per rule mentioned earlier, pancreatoduodenectomy is done, and after removing any stones, duct is anastomosed to jejunal loop as standard in Whipple's. Scenario 4. Enlarged head with normal or uniformly dilated duct. As per rule, Duodenum-preserving pancreatic head resection is done, but common supply of duodenum and pancreas is a challenge. BERN devised a procedure where pancreatic neck is transected over portal vein as done in Whipple's, and pancreatic head is removed with a small rim of parenchyma along duodenum and posteriorly. CBD may get exposed. Both distal pancreas and head cavity are anastomosed to jejunal loop. If CBD stricture is present, then it can also be anastomosed to pancreatic wall. One problem with BERN is that in chronic pancreatitis fibrosis causes adhesions of pancreas with surrounding structures including portal vein, hence chances of bleeding is more in BERN modified duodenum-preserving pancreatic head resection. He cored out pancreatic head like BERN, but did not transect pancreas over neck, hence decreasing chances of bleeding. Similar to BERN, jejunal loop is used to anastomose duct. If head is enlarged with ductal obstructions or strictures, then both coring of head with ductal drainage is needed. FREY procedure is done, which includes coring of head with longitudinally opening the duct. Anastomosis is done with jejunum. Scenario 6. In case chronic pancreatitis is limited to left side, distal pancreatectomy is done, and in scenario where whole pancreas is involved with severe pancreatitis and patient is already insulin-dependent diabetic, then total pancreatectomy is done, as its most important complication is fragile diabetes. Let us revise. Ductal dilatation more than 7 mm, without mass. Lateral pancreaticojejunostomy LPJ is done. Pancreatic head mass. Pancreatoduodenectomy, which can be pylorus preserving. Enlarged head, no suspicion of malignancy. Duodenum preserving pancreatic head resection. BERN. Frozen section analysis is always done to exclude malignancy. Small mass in head, ductal obstruction in head entail duodenum preserving pancreatic head resection. FREY. Isolated tail involvement. Distal pancreatectomy. Severe changes in entire pancreas with pre-existing insulin-dependent diabetes. Total pancreatectomy. Subscribe YouTube channel Concepts of the Surgery for best video lectures on surgical topics.